Welcome to this explainer. Look, if you're in radiation oncology residency right now, you absolutely know the anxiety that comes with follow-up scans for spinal metastases. You've mapped it out, prescribed the dose, delivered the SBRT, and now you have to interpret the results at tumor board. Well, today, we're diving into some fascinating data, showing how multimodal nuclear imaging might just become your absolute best tool for evaluating that post-SBRT response.
All right, here's our clinical roadmap for today. We'll be covering 1. The MRI interpretation dilemma, 2. Evaluating nuclear metabolic response, 3. The impact on local control, 4. Predicting overall survival, 5. Early imaging and clinical timing, and finally, 6. Spotting pseudoprogression in practice.
Let's start right in with Section 1, the MRI interpretation dilemma, or basically, what happens when structural imaging falls short. This is a universal resident headache that you'll deal with on practically every single follow-up. Is it progressing, or is it just pseudo-progression? That is the classic question, right? When you're staring at a difficult post-SBRT MRI, you constantly have to ask yourself if what you're seeing is true tumor growth or just a treatment effect. And the stakes here are super high. Misinterpreting this can mean sending your patient for a totally unnecessary biopsy or even salvage surgery. Now, we all know MRI is the gold standard for soft tissue contrast and detecting tumor infiltration. But post-SBRT, the structural changes get really messy. We're talking radiation-induced fibrosis, osteoradionecrosis, vertebral compression fractures. All of these structural changes can easily mimic true tumor progression. That structural noise introduces a massive risk of misdiagnosing pseudoprogression, which is exactly why relying just on morphologic imaging can lead us astray. So how do we fix this? Let's jump into Section 2, evaluating nuclear metabolic response. Let's look at the framework of a study from Advances in Radiation Oncology that aimed to cut through that exact structural noise. The researchers evaluated a retrospective cohort of 53 patients with spine metastases who were treated with SBRT. They specifically focused on pre- and post-treatment PET scans, primarily FDG PET or bone scans to assess the nuclear metabolic response. They essentially wanted to see if functional imaging could give us the clarity that MRI couldn't. And looking at the demographics, it's a really diverse group. We have a median age of 61, featuring breast, lung, and prostate adenocarcinomas, with about 72% of the tumors having a radiosensitive histology. But the most incredible takeaway here? 74% of these patients ultimately achieved a metabolic complete response, or MCR, on their nuclear imaging. Which brings us to Section 3, the impact on local control. Let's break down why achieving that metabolic complete response actually matters so much for your clinical outcomes. The contrast here is literally night and day. Check this out. We're looking at an exceptional 97% 2-year local control rate for patients who hit that metabolic complete response. Compare that to just 60% for the non-responders. That is a massive difference in outcomes, based entirely on what the functional scan is telling us. And the multivariate analysis confirms just how powerful this relationship is. When you're framing this for your next patient consult, remember that an unbelievable hazard ratio of 12.76 means an MCR is a huge, independent predictor of keeping that spinal disease in check. If the PET scan is completely quiet, the odds are overwhelmingly in favor of durable local control. Local control is vital, absolutely. But let's shift to Section 4, predicting overall survival, because this nuclear imaging response actually stratifies something even larger than just the spine. This Kaplan-Meier curve brilliantly illustrates the survival gap. That top line represents the patients achieving a metabolic complete response. They are sitting at a 2-year overall survival rate of 76%. Meanwhile, the non-MCR group on the bottom line is at just 36%. Hitting that complete metabolic response literally doubles the patient's 2-year survival probability. The multivariable analysis backs this up, proving MCR is an independent driver of long-term overall survival with a hazard ratio of 4.03. But actually, look at that second point. Stable systemic disease is also a massive predictor with a hazard ratio of 5.27. It's a great reminder that even when we are hyper-focused on treating the spine with SBRT, the patient's systemic disease is still running the show in the background. Okay, moving to Section 5, early imaging and clinical timing. The prognostic value is crystal clear, but the next logical question for your practice is, how soon should we actually be scanning these patients to get this data?
If we look at the early response data, imaging performed within just 3 months of SBRT can confidently spot who is successfully responding to your prescribed dose. In fact, the median time to imaging for this early cohort was just 1 month. Astonishingly, patients who achieved this early MCR at 3 months enjoyed a perfect 100% 2-year local control rate. Let that sink in for a second. A quiet PET scan within 90 days of radiation correlated with 100% local control at 2 years, compared to just 40% for the non-MCR group. This makes early nuclear imaging an incredibly powerful surrogate marker for treatment success. Let's bring this all into the real world with Section 6, Spotting Pseudoprogression in Practice. We're going to review 2 actual radiographic clinical cases from the study where the MRI and PET told completely different stories. This is exactly what you're going to see in the reading room. Here's our first case, a C2 lesion. The follow-up MRI at 48 months looks terrifying. It shows an enlarging, enhancing mass. By standard MRI criteria, this looks extremely concerning for true progression. But look at the concurrent PET scan right next to it. It reveals a metabolic complete response. There's no active tumor there. This is a classic textbook example of pseudoprogression, where functional imaging stops you from making a drastic clinical error and honestly saves you from getting yelled at by a spine surgeon for an unnecessary consult. We see the exact same phenomenon here with an L4 lesion. The post-treatment MRI at 9 months suggested failure with a clear increase in lesion size. But again, the PET scan reveals a near-metabolic complete response. That lack of metabolic activity saved this patient from an unnecessary biopsy or really heavy-handed salvage therapy. It proves that structural enlargement post-SBRT does not inherently mean active disease. So, as we wrap up this explainer, I want you to think about your next clinic day. Armed with this data, how will you use multimodal nuclear imaging to confidently de-escalate interventions, manage pseudoprogression, and adapt your radiotherapy strategies? The next time a structural MRI gives you a dilemma, remember, a functional scan might just give you the answer. Thanks for hanging out with me on this explainer, and I'll catch you next time.